Thank you for tonight's educational webinar on common knee injuries in sports and how to tell when a knee injury is serious. Tonight's speaker is Dr. Rodney Comisar, OrthoNeuro orthopedic surgeon and sports medicine specialist. Dr. Comisar is a board-certified and fellowship-trained orthopedic surgeon who specializes in sports-related injuries. He offers a full spectrum of sports medicine surgery, including arthroscopy and minimally invasive procedures. Dr. Comisar's areas of special interest include ACL reconstruction, multiligamentous knee injuries, dislocations, shoulder and patella instability and dislocations, rotator cuff injuries and tears, proximal hamstring ruptures, biceps and triceps injuries, and shoulder arthritis, including total shoulder replacement and reverse total shoulder replacement. Please type questions in the Q&A box below, and Dr. Comisar will answer questions following his presentation. Dr. Comisar?
Good evening. Thanks for tuning in tonight. As Heather said, I'm going to run through some common knee injuries that occur in sports that we see, also with the subject or subtitle of how to tell when an injury is serious. We're having a little technical issue, so I hope you can hear me and see me okay. I'm kind of running off my phone. Can you go to the next slide, please? So to better understand knee injuries, it really helps to know the anatomy. That's kind of what the foundation of what we do in orthopedics is based on. So in this slide here, on the far left, this is a copy of a right knee. You can see the quad muscles. There's kind of 4 components. You can see 3 of them there that become the quad tendon, your kneecap or patellar, and then patellar tendon runs from the bottom of the kneecap. So that's kind of what we call the extensor mechanism. That can be important in sports participation, among other things, certainly. The central slide is basically a picture with the kneecap or patella removed and knees bent 90 degrees on a right knee again. So important structures are what we call the trochlea, which is like that off-colored surface on the end of the femur. That's the articular cartilage. That's kind of what the kneecap glides in. And below that is the tibia. You can kind of see there's some similar cartilage on either side of the tibia. Those ring-like or C-like shaped structures are called the menisci. So the meniscus is another form of cartilage, and it really just serves as a shock absorber between the femur and the tibia, and specifically its articular cartilage. Lastly, in the middle, you can kind of see what we call the cruciates, the anterior cruciate ligament and the posterior cruciate ligament. Cruciate stands for cross, so they kind of crisscross in the middle of the knee and help control rotation and stability. And lastly, in that central slide, the other important anatomic structures are the medial and lateral collateral ligaments, and they kind of stabilize the knee, and they're located outside the joint, whereas the cruciates are inside the joint. Lastly, a top-down view of the tibia with the 12 o'clock position representing up or anteriorly, and then the 6 o'clock position would be posteriorly. This is an example of a right knee as well. One thing just to note is the size of the meniscus is different on the inside or medial left side and laterally. You can see the lateral meniscus is larger and it covers more of that articular surface of the tibia, and that has some kind of relevance when we treat these injuries, and also with respect to minimizing the risk of arthritis as our patients get older. Could you give me the next slide? So joint sprains are very common in sports. You know, many of you have perhaps sustained them. Certainly the knee is frequently affected just by nature of the sports that many people choose to participate in. Nearly 50% of these injuries we think occur in the 3rd decade between ages of 20 and 29 years of age. Roughly 2/3 affects males. It may just be by nature of the volume of participation, also the type of sports. Male injuries, interestingly, tend to be more of a contact type of injury, whereas female injuries are predominantly non-contact in nature, meaning more, hey, I landed from a jump, no one bumped me or struck me, it just happened. So different types of sports-related knee conditions, one way to break it down is really between traumatic injuries, which occur with like an event or an episode, and then the overuse injuries, which occur more atraumatically. They just evolve more over time. Certainly traumatic injuries can vary from fractures, tendon tears, ligament injuries, to some of those collateral and cruciate ligaments we talked about, meniscal tears, and also instability where the kneecap can come out of place in some cases. Common overuse injuries or the atraumatic variety. Well, there's several that we may reference at the end here. Anterior knee pain refers to the kneecap. It's also termed patellofemoral pain. Sometimes you might hear the term chondromalacia. That's something that it doesn't just happen. It tends to evolve over time and can be somewhat degenerative in nature in certain cases. IT Van Friction syndrome is another overuse problem we see frequently in runners and sometimes cyclists. Generally, muscle strains can happen and really all walks of life and all kinds of sports and job participation, and they can vary in severity. And patellar tendonitis is another common one we see in young athletes. The jumper's knee, you might hear it termed. We see it in basketball a lot. So the mechanism of these injuries, we're going to kind of focus more initially on the traumatic type injuries. So whether it can be a direct blow while someone's playing football, I got hit from the side of my knee. Commonly in basketball, a girl, she might land from a jump in volleyball. I spiked the ball and came down, landed awkwardly, and my knee gave out. Pivoting, hey, I stopped, a jump stop, changed directions on the basketball court, my knee caved in. Twisting, turning, pivoting, more like a rotational problem. Certainly it fall directly onto the knee. In certain sports like wrestling can do it. And even a squat, sometimes I got down into a squat, whether I was catching or coming up off the floor, doing a CrossFit workout, whatever, those things that can also lead to traumatic knee injuries. And then again, the atraumatic ones, they don't really have a specific mechanism. It's more related to, hey, I was doing this for the last 2 weeks and then I ramped it up and now I started having some symptoms. So just to back up some basic definitions, how we kind of think about these problems or injuries. A sprain is typically refers to an injury that affects a joint and or a ligament around the joint. You might remember that MCL and LCL in the anatomy slide, they kind of cover either side of the joint. So that's when we talk about sprains, it's typically more of a joint problem. Strains, conversely, tend to affect more of muscle, a tendon, or some combination of those two, because typically the muscle is connected to bone by the tendon, so the musculotendinous unit, and that's when we talk more in terms of strains, like, hey, I strained my quad muscle. And then contusions, which really can represent a wide range of injury, from any kind of blow to the knee or a fall directly on the knee. That can just affect the soft tissues where you get a simple bruise, or a bone injury, which is sometimes harder to ascertain, certainly not with the naked eye, but that's something that may be reflected in MRI, and we term like the bone bruise that you might have heard of. Next slide. Further to go into more detail on these definitions. So the sprain affects the joint, the ligaments, or the joint capsule, which is kind of like the lining of the joint. And it tends to occur in degrees. We grade it like mild, moderate to severe, or 1, 2, 3 with respect to the severity of it. Similarly, the strain affects that muscle or tendon unit. Also tends to occur in degrees, tends to be lower or intermediate grade. Primarily, they're partial tears. You partially tear your muscle or your tendon. It's pretty rare to tear your muscle in half. I mean, certainly you can rupture a tendon, like a quad or patellar tendon in this case. I'm talking about the knee. But in general, the strains are more lower grade and often can be treated conservatively and improved with time and appropriate rehabilitation. So ligament injuries, it's the biggie this time of year as we start to head into the summer and fall. We're talking about soccer and football and high propensity to sustain these problems. ACL tears is kind of a popular buzzword, just one, because it happens and it's so devastating because of the duration of the recovery, but also the challenges of getting back to sport. Certainly there's a very high incidence in females, young athletes, anyone under 25, essentially. Typically it's an all or none injury, which we'll talk more about. And generally it's become surgical. MCL tears, conversely, you remember the anatomy there where the ACL is in the middle of the knee, to maybe have limited healing capability because of the synovial fluid. MCL tears, conversely, on the outside, they have a better access to blood supply. They can often be treated non-surgically. They're typically more contact injuries. You don't just sprain your MCL without having someone typically bump into you from the side. Alternately, it can happen with certain twisting or torsional mechanisms, such as when you're skiing, you have a big lever arm on your foot. I'm not going to spend a ton of time talking about some of the other ligament injuries like the PCL, the LCL, and what's the PLC, which represents the posterolateral corner. Injuries to these structures are much less common. They often will occur in higher energy injuries, but also can occur in conjunction with like an ACL injury and MCL injury. So they're often more combo injuries when you have this kind of alphabet soup descriptors of these knee ligament injuries. So go into ACLs a little bit more, as we said, a high incidence in female athletes, particularly patients under 25, and certainly typically in cutting, pivoting sports, so that can happen in people of all walks of life, laborers, etc. Generally, as we said, it's a non-contact mechanism, particularly in our females, where there's an incidence of 2 to 8 times the rate of injury in females than males. Generally, it's an all or none injury. They're really for a long time are felt to be no partials. I'm sorry it doesn't project well, but on the top right there, that it shows the ACL from the front and the side, and there's kind of 2 bundles. So it's thought that generally both bundles tear. There's some instances where there is only one bundle affected, and there's been some described as partial tears that may be able to be repaired in a limited settings, particularly in some of your pediatric age patients. Often these ACL injuries have other associated injuries to the knee, which involve the meniscus, sometimes the articular cartilage, and or other ligaments. The combination of ACL, MCL injuries frequent, and then with some of the other cruciate collateral ligaments less commonly, but can happen. And those can really suggest a more significant or high velocity injury that really has done a lot of damage to the knee. As we said, the ACL injuries are typically surgical. The results overwhelmingly support this. Someone that's low demand, older patient may get by with bracing and therapy and activity modification, but principally the treatment is surgical. As our patients get older, they get more active, and nevertheless, they want to kind of have a knee that allows them to do what they want to do. Reconstruction can constitute using what they call autograft, which is like a tissue from your own knee, like your patellar tendon, or your quad tendon, or your hamstrings, or alternately allografts. That's typically reserved more for patients over 35 or 40, lower demand, patients maybe with some early arthritic problems to their knee. The other thing that's kind of come into vogue in the last 5 years or so, there's not only the repair thing we talked about for partial tears, or what we call proximal tears, meaning tears that kind of pop off the femur as opposed to tear in the middle or shred, is a repair. And the repair can be, there's a proprietary system termed the Bear procedure, which I've done one. It's a collagen product that you kind of soak in blood, and you basically put it over the front of or the top of the repair in the middle of the intercollar notch of the knee. And it's shown some promising early results with respect to treating some of these patients with the appropriate anatomic location of injury with a repair as opposed to reconstruction. The purported advantages are it tends to feel more like the normal knee for the patient. You don't tend to lose as much quad strength and have as much difficulty recovering post-operatively. And heaven forbid if they do re-tear it, you're kind of starting over with essentially a fresh knee, or quote a virgin knee, where there hasn't been any surgery to it, in the form of like drilling tunnels and things, which you typically have to do with the reconstruction. So it's showing some promise. I'm starting to offer it to certain patients, and I guess I'd say stay tuned, and we'll see what the results look like down the road. Next, please. MCL injuries, typically, as we said, a contact injury with the foot planted. Classic is a deep offensive lineman. He's engaged with the defender, and someone falls into the side of his leg. So blow to the side of the lateral side of the knee with a foot planted, and typically kind of stretches the medial structures. And less frequently, we'll see it in a twisting mechanism in sports, or the common scenario would be skiing, where you got this big lever arm on your foot that catches in the snow and it kind of torques you. And if you're lucky enough not to tear your ACL and just tear your MCL, that's something that can often be addressed non-surgically. As we said, that these injuries tend to tear in degrees, mild, moderate, severe. It's very infrequent that we wind up doing surgery on them. It's really more if the MCL is torn and it almost kind of continues to tear around the back of the knee to the midline, what you call the posteromedial corner, where it just leads to instability and with knee extension, and it's kind of a more significant amount of instability than your custom or classic MCL injury, if you will. We think one of the reasons these can be treated conservatively is because the ligament is outside the joint. It has more access to blood supply. Specifically, most of these injuries on the femoral side, there's good blood supply. It's what we call extra-articular, so there's good ability to heal. And where once upon a time, years ago, they would treat ACL injuries non-surgically in a cast, and they would operate on the MCLs, and the ACLs did poorly, and so now we operate on them, and then the MCLs often got stiff, and so there's been a move over the last several decades to really try to treat these primarily non-surgically with braces, crutches rather, protective weight bearing, and then some early therapy to get them moving so they don't get stiff. Because these patients with MCLs of really high, medium, or low grade injuries can get stiff, both with trouble getting their extension back, but also their flexion. As I said, occasional surgery, it's probably something we do once or twice a year, if that, often in conjunction with a combined ligament injury, like with associated ACL and or PCL injury at the same time. But pretty infrequent we have to operate on the MCLs. Certainly Tom Brady was a classic example, probably, I don't know, 20 some years ago when he first got hurt, and maybe 15 years towards ACL and had this MCL injury as well. Next, please. Talking a little about dislocations. The knee dislocation is a little bit beyond the scope of this talk, but you're talking like injuries to generally 3 to 4 ligaments, car wreck, motorcycle wreck type of injuries, falls from height, really significant, that basically the femur and the tibia separate. It's really what's considered an orthopedic emergency. Don't really see them as much in the sports arena, although the bottom right picture of Sean Livingston, he had quite a significant knee injury years ago and actually recovered and came back and played for many years afterwards. Much more common when we talk about dislocations of the knee is patellar instability or patellar dislocation. So dislocation means the kneecap kind of jumps the tracks, like that picture in the bottom left, where it's completely out of place. In some cases, that can be kind of reduced by the patient on their own. And sometimes, in my case, I did it once. I had to go to the ER and had it reduced or put back in after a couple hours. That was pretty miserable. So the patella can slide in and out of place. It typically happens with the knee kind of near full extension or early flexion. The more bent your knee is, the kneecap is kind of centered in that groove and it really doesn't have a lot of mobility. You can kind of test it on yourself. It's a pretty stable position. So most of the time, these injuries happen from like zero, like full extension of the knee, to maybe 20 to 30 degrees of knee flexion. The subluxation is when it kind of goes out part way and then pops back in, which also can happen. Some people feel that more frequently and can tolerate that. Obviously, the dislocations can be problematic. The dislocations of the patella tend to happen in younger patients, particularly adolescent females, are a high-risk group. And once they happen quite often, the tissues can get so stretched out where it becomes increasingly easy to do it, if you will, where it's like easy out, easy in, where they can have it pop out and they can just put it right back in. The downside of that problem is each time that patella jumps the track, so to speak, the patella can hit the cartilage on the inferior medial board of the patella, kind of hits the cartilage on the lateral aspect of the trochlear or femoral groove, and you can get cartilage damage, sometimes knock off chunks of cartilage and or bone in certain cases where they have to be removed or in some cases repaired. And certainly repetitive or recurrent dislocations can lead to progressive arthritis that often will be manifest as the patient gets older. Say they're 20 to 30, this is happening a lot. Then when they get to 30 to 40, the kneecap instability problem is less of an issue, and then they start developing pain because their articular cartilage is damaged. So it's not a benign condition. We do a procedure called a patellofemoral ligament reconstruction, where you basically kind of recreate that ligament that holds it in place. As soon as you dislocate that ligament, it's kind of stretched or torn, and then even though it may tighten up a little bit, it tends to be stretched beyond its normal length. And so then it just puts that patient at higher risk of recurrent dislocations. We typically use a graft, either a hamstring from the patient or a hamstring from a donor, to kind of reconstruct that patella. And so that would run from that kind of medial or left-sided board of the patella, if it was back in the groove, to the around the corner on the left side of the femur there. And that would kind of be like a check rein to keep that from jumping the tracks again. Some patients have so much malalignment or deformity where they're kind of knock-kneed and they're wide at the hips, particularly more in females, that there's such an acute angle with the pull from your quad to your kneecap and then back to that patellar tendon attachment that it wants to kind of drive the patella out. And in some cases, we do something in conjunction with such a patellofemoral ligament reconstruction called a distal realignment, where we actually have to cut the bone of the lower leg and kind of slide the patellar tendon insertion on the tibial tubercle over several, like say a centimeter, just to kind of change the angles and improve the vectors so it doesn't want to pull the patella out. Because some patients will, if you do this MPL reconstruction alone, will fail just based on some anatomic variables that they have. Next, please. Meniscal injuries or cartilage tears, you might hear people reference that. Very common, really, patients of all ages, from teenagers up to, patients in their 70s and 80s. The difference is the older patients tend to have some concomitant arthritis that may be the underlying problem, and the meniscus is typically not torn and acutely from an injury. Whereas your 16-year-old basketball player, hey, I twisted, turned, pivoted, felt a pop on my knee. Sometimes it's coming off the floor, off the mat. We see them a lot in wrestlers, especially on the lateral compartment. The patients may or may not feel a pop. The pain tends to localize to either the inside or outside of the knee. They often get swelling, but not every time. They may describe a feeling of their knee catching or locking, both. Whereas if they can't get their knee straight, there's a condition where you can get what's called a bucket handle meniscus tear, where the meniscus actually like flips, the inner part tears, it flips like a bucket handle, and it can keep the knee from going straight. And those patients tend to localize their pain to the front of the knee, immediately or laterally, kind of adjacent to the patella. Conversely, just your garden variety or regular meniscus tear or cartilage tear, a lot of these patients will just have pain where they can't bend their knee fully. The higher inflections, say past 90 degrees, they get pain, particularly with medial meniscus tears, which are a little more common. So those are some kind of indicators that you can look for. So to tell you a little more about the meniscal injuries, the meniscus, as we talked about in the first anatomy slide, it's a protector of the knee. So it cushions the articular cartilage, kind of shares the stress. So if you don't have all your meniscus, guess what? More stress to the articular cartilage, which can allow it to wear and then develop progressive arthritis. Now, the majority of these meniscal tears occur in the zone of poor blood supply, or what we call the white zone. So if you look at this, and I'm sorry it doesn't project better, but the far left slide basically is like a cross section through a knee with the femur up, the tibia down, and the meniscus, that kind of wedge shaped structure. And what this shows really is they did some dye injection studies where the blood supply comes in from the left, and it kind of only penetrates part of that meniscus. And you can see how the inner, like 2/3 roughly, has no dye in it, which basically means there's little to no blood supply to that area. Thus, one, that's why that area is a more common zone of tears occurring, but two, there's relatively limited healing potential or capability of that area. What I was trying to show with these the second slide from the left, the bottom right portion of it kind of shows 3 zones. You can kind of see like an outer area, an inner area, in the middle. The inner zone is what we call the white zone, which is where most of these meniscal tears are. That's where that one in the third picture from the left, that's kind of an inner zone tear that you would just trim out. Then you get to the middle zone, which is kind of a gray zone, or they call it red-white, which means some blood, but some avascularity to it. And lastly, the outer rim is the red zone. So those are the ones that we like to see. We see them a lot in conjunction with ACL tears. We can repair those in many cases, or at least give it a try. And certainly the younger the patient, we're going to make every attempt to salvage the meniscus, because we know once it's out, it's out. It's not growing back. It's hard to replace it. I mean, you could do some meniscal transplants in certain cases, but there's nothing like having your own tissue heal up and work for you. So as I said, that the treatment is really dictated by the zone of the injury. On the far right, that one's kind of a little more red-white. It's not a huge area, so you could trim it out because it's not a big tear or big area that you'd have to resect. However, in conjunction with an ACL tear where you have a lot of blood in the knee and healing potential, you might try to stitch that just in the interest of preserving meniscus. So it really comes down to, is the tear in the central or inner part of the meniscus versus a peripheral tear. Another type of tear we started to see and recognize more frequently is called a root tear, which is kind of really the anchor points of the anterior and posterior aspect of meniscus, maybe beyond the scope of this talk. So I'm going to kind of move on. Would you mind flipping, Heather? Certainly fractures about the knee, not very common. We call it macro fracture, or actually a full-blown fracture. So that picture on the right there is of a kneecap or a patella fracture. You can see the thing's kind of cracked in half, and it's also a little bit rotated, like the cartilage, smooth cartilage is kind of pointing up on the bottom piece. So that's a complete displaced fracture that needs to have surgery. Less commonly, other types of fractures we'll see are in pediatric patients. They'll get fractures of what's called the tibial tubercle, which is kind of the zone where the patellar tendon inserts, but there's kind of an angled growth plate in those patients that can kind of pop off and or hinge up, if you will, and that's definitely a surgical indication as well. Much more common are like our MRI fractures, what they call microfractures or bone contusions or bruises. We'll see when we're getting MRIs of these injuries because they're commonplace, as you can imagine. And typically those bone injuries or excuse me, or bone bruises occur in conjunction with your patellar dislocation, with your ACL tear, or even an MCL tear where you hit so hard from the outside of the knee, it stretches or tears the MCL on the inside, and the bones on the outside or lateral compartment kind of bang together, and you get a significant bone injury. So sometimes when you see that in the event you've gotten an MRI, it kind of tells you, wow, that was really a pretty significant MCL or pretty high energy injury. So how do we evaluate these patients? For our initial evaluation on the field and sideline, you want to be pretty quick and efficient, but certainly thorough as well. So typically when you're working the game as a physician, you're watching the action. You don't want to be talking, you're not eating, you're watching the game. So, you know, when something happens, you've already seen what occurred for the most part. You can, and unless they're in a crowd, of course, but you can see the mechanism of injury. So what happened? If you didn't see it, you can ask the athlete, hey, what happened? Did you get hit? Did you twist? What have you? Did you feel a pop? Also, where does it hurt, if at all? And then can you walk? One, can you stand and walk? And then two, if you can walk, how do you feel about, can you continue? And some of that's predicated on what else you think as a physician or a trainer has happened, but in the rest of your evaluation. But those are all kind of important questions to ask. Now, when you see them in the office, it's a little bit later. It's not fresh. It didn't just happen. So you might say, hey, when did this happen? Is this yesterday? Is this 2 weeks ago? Tell me, you know. And then other important questions are, hey, did you get swelling? If so, did it happen immediately, which can be suggestive of certain types of injuries, or was it something that occurred more gradually, if at all? Another classic terms patients might use is, hey, my knee catches or locks up, I can't move it. Does it give out? Can you put weight on it? And then in those patients in the office, when you have a little more time, you can ask them, okay, have you ever had this happen before to this knee or the other knee? Have you ever had any treatment of any type, or including surgery in the past on this knee? Because the evaluation is not so abbreviated. It's really on the field. You're just trying to triage it, determine, hey, is this one, can they get up and get off the field where you can take them to the sideline and do a little more thorough evaluation, but you want to do it safely. Because the time and place is not to sit there on the field and delay the action and go through a real extensive examination, if you will. Next slide, please. So our initial exam on the field, we're looking tenderness to palpation and kind of hit the common areas, the kneecap, maybe the medial lateral joint lines where the meniscus occurs. You can check the insertion points of the medial lateral collateral ligaments. Also, knee range of motion. Can they move their knee? Can they straighten it? Can they bend it? Assuming there's no deformity when you're looking at them. And lastly, do a quick ligamentous exam. And these pictures kind of show on the left what's called a Lockman, which is kind of a classic or gold standard assessment for an ACL. And then the one on the bottom right is where we can do what's called an anterior and posterior drawer test, which are helpful for an ACL and really helpful for a PCL injury. And then lastly, if you walk on the field and you see his kneecap dislocated, like on the top right, all bets are off. You can try to reduce that on the field if possible. If not, you might, sorry, my dog's making noise up there. If you can pop it back in place and put them out of their misery, so to speak, that's desirable, but sometimes if it's not reducible or they can't relax, their muscles are in spasm, you have to splint them or brace them that way and send them, perhaps by squad to an emergency room to get some sedation. In an office setting, you can watch them walk. Can they put weight on? Are they limping? Are they using crutches or what have you? You can look at the skin, any kind of lacerations or abrasions, which might suggest that, hey, a fall to the knee, or did they just have a ton of swelling and bruising about their knee? Do they have, when they talk about swelling in the knee, we refer to it as an effusion, meaning you can have swelling around the knee, but not fluid in the knee. And then you can have an effusion, which is actually fluid in the knee, which you might see with a traumatic ligament tear, a fracture, and the like. We'll check the extensor mechanism, meaning can you straighten your knee from a sitting position? Can you do a straight leg raise? Those are things that kind of show us that whole extensor mechanism is connected, meaning the quad muscle to the quad tendon to the patella and down to the tibia. If not, then you raise suspicion of perhaps there's an extensor mechanism injury, typically like a patella or quad tendon injury or a tear. And next in the office, again, you have a little more time. So you can do what we call our provocative test, where we expand on those ligamentous exams, but also look at the meniscus, check the patella, etc. So how do you know when a knee injury is serious? Well, in general terms, was there a traumatic event? Typically something that just started hurting out of the blue isn't going to be that bad or serious for the most part. Did they get hit? Did they fall on it? Land from a jump awkwardly and they can't walk? Those are kind of good indicators where they, hey, I can't walk, or I'm limping like crazy. So if they don't even think about trying to go back on the field, that gives you an idea of, hey, this is pretty significant, because otherwise, this kid normally would walk it off and he'd be back on the field. Did they feel a pop? Did they get rapid swelling? Certainly a rapid swelling can be indicative of a few things that, such as an ACL tear, sometimes a patellar dislocation. And if you have gross deformity, like we saw with a patella on the previous slide, then that's something that, hey, this merits a little more attention. How to tell when a knee injury is serious? Well, can you flip it for me? Bigger questions like, when do we go to the emergency room? Certainly the gross deformity, like the guy on the right there, or the 1-2 slides back. That patella may need to be reduced. Even if you reduce it, it's probably best to get an x-ray of that. If you can reduce them on the field and then get one, it's okay. But if it won't go back in, you're certainly going to want to get an x-ray before you try to sedate him and reduce it, just to make sure there's no fractures. And then also, once more so in the shoulder than the knee, you want to get them afterwards, because it's pretty obvious when the kneecap goes back into place. Shoulder sometimes can be a little trickier. And then you may need to brace that patient with some kind of knee immobilizer or brace to just provide them with some stability, so they don't feel like, hey, this thing's going to slip out again. Another emergency room kind of criteria is if you have a skin laceration, any kind of deeper laceration that might require suturing, it's really best handled with washing it out and then suturing it within 8 hours. So if you wait longer than that, technically you shouldn't close it. There's concern about, you're closing it up and there's a higher rate of infection and problems with the healing. So really those lacerations and wounds that require suturing are best served within 8 hours after they're thoroughly cleaned. And lastly, we alluded to a little bit before, if the patient can't walk at all, that raises some red flags. You can try to get them crutches. And if they're still hesitant to weight bear, that may kind of heighten your sense of urgency about, hey, do I need to get them seen right away, either for x-rays and the like, and going forward. Can you flip? So there's one of the ER literature came out with some Ottawa knee rules, which are rules that really govern, like, hey, what's the suggestions for when we get x-rays here? So if the patient can't walk, you should get x-rays, and that typically applies to ankle injuries as well. If they can't bend their knee to 90 degrees, probably reasonable to get x-rays. Chronic problems in your older athletes, that can kind of a whole different subset of problems. Some of those patients have arthritis, but any doubt, when you're treating these patients, get x-rays, because a lot of times arthritis is their main problem and they may not even know it. And also if they have point tenderness or focal tenderness, such as over the patella, sometimes over the fibula where the LCL inserts. Other relative indications for x-rays are the pediatric age patient. Open growth plates, they can get fractures and injuries that the rest of us aren't really prone to. And those patients are best served with x-rays in the acute setting after an injury. And you can see that x-ray on the left, that was that tibial tubercle avulsion fracture I was talking about. You can almost see it looks like a beak where it should be kind of tucked down. And instead it's kind of hinged up. So that would be something that would be reduced and then fixed with a couple screws. The top right demonstrates that knee dislocation, that serious high energy trauma that's an orthopedic emergency. You want to get that reduced as soon as possible. And also those patients tend to be observed, if not for 24 hours for serial exams in the hospital, but also to look at some of their neurovascular structures, because there's a higher incidence of arterial injuries in those patients where it can be limb threatening. So not to be taken lightly. And lastly, the one on the bottom right, it shows a high grade kind of LCL injury where that is totally gapped. Typically to get that much gapping, you're already torn your LCL, but then typically your ACL and or PCL are also at risk to get that much deformity or separation. That's kind of an extreme case. You don't tend to see those as much with LCLs because normally your LCL, the inside of your knee where you get hit to have something like that happen is protected because your other leg's typically in the way. Whereas in football, you typically get hit more from the outside, which it takes out your MCL. So that's an interesting x-ray, but probably a less common scenario. Excuse me, can you flip for me? So this comes up a lot, when to consider an MRI. In this day and age, in the sports world, everybody gets an MRI for a hangnail. So now it doesn't really apply to the average patient population, myself included. And what are the reasons for that? Well, typically, you get an MRI when you think it's going to change your treatment, or if you're not sure what the diagnosis is. Some of it's a little more governed by insurance as to whether they'll pay for an MRI anymore. Generally, if there's some kind of traumatic injury or event associated with the episode, that you have a little more supporting information, they'll provide for that, but not always. Certainly, traumatic injuries with a large effusion, meaning massive swelling, and we'll often take that out. If the knee's grossly unstable, traumatic injury, large effusion. So what caused that? Thinking fracture, ligament tear, etc. That's where you get the MRI. Similarly, gross ligaments instability, like some of those x-rays we saw when there's, clearly a high velocity injury to the knee, multiple structures are affected. If you see an obvious deformity, it's a good indication to get that MRI, so you kind of really put all the information together, because it really complement what information, if any, you get from the x-ray. Certainly, as we talked about, unable to fully extend that knee fully, in the event of like a twist and a pop, you're thinking, hey, did they tear their meniscus? Do they have one of these bucket handle tears where they can't get their knee straight and it's kind of flipped in the front and it kind of hurts towards the front of the knee? Similarly, if they can't do a straight leg raise, we talked about that. Often a little bit older patient, not your adolescents, but more like your really 25 to 40, you're thinking patellar tendon tears, over 40 to 50 and above, possible quad tendon tear. And that means, hey, they can't straighten their knee, or certainly they can't do a leg lift where they get their heel off the table. Now, granted, that can occur just because of the pain associated with the injury and or swelling associated with, but that's at least raises your index of suspicion, like, hey, I have to rule that out. If I can't tell clinically well, then I might have to, get an MRI here. And then certainly if there's an inconclusive exam, more and more, frankly, we get MRIs because patients want them and they say, I want an MRI, and say, okay. Now, sometimes the insurance won't let them, but we'll at least try to facilitate that. And ultimately, if you're at a crossroads with your treatment, and you're not sure what's going on, you're going to get the MRI. Flip, please. So aspirations, when do you do this? Aspiration refers to drain the knee, get the fluid out. When do we do that? That large effusion after a fracture or ACLs are common where they get a huge effusion. Taking that out can give them comfort. It can also sometimes help them do a straight leg raise. So if you see a patient with a huge swollen knee, we can drain it, get the blood or fluid out, and then often that actually helps them reduce their pain enough, and then suddenly they can lift their leg, whereas, hey, maybe they couldn't do that 5 minutes ago. Similarly, when they have significantly limited flexion, we do this a lot post-surgically. when they have a big swollen knee and it's affecting their progress with physical therapy. And then sometimes if they have a lot of pain at night, especially if I see the patient has had this injury, they're swollen, they come in, they can't sleep. A lot of times that can be due to blood in the knee. And typically if you do that, if you aspirate the knee, it can also give you information on the diagnosis. And in this case, if you see a big bloody knee when you aspirate it, certainly ACL tears are the number one reason we'll see this. Certainly any kind of patellar dislocation and less commonly subluxation event where it kind of partially pops out and back in can lead to a bloody effusion. Sometimes the patellar dislocations can have double the size of the blood in the knee than the ACL tear. Fractures, which typically you're kind of aware of by then because you've already x-rayed them. And then less commonly, a real peripheral meniscus tear where all that red zone is we talked about, you can get some blood, although that's kind of a one-off, pretty rare occurrence. Now, if you drain the knee and it's clear fluid rather, it's more common from a meniscal tear in the central to mid aspect. Certainly with bone bruises that happen with ACL and MCLs, especially over time. Say it's an MCL with no acute tear of the ACL. Excuse me. The bone bruise itself can lead to an effusion that's often a clear effusion that we drain. And just arthritis and even chondromalacia, like early softening of that cartilage, can lead to it. If you had a workout or went for a run and kind of pushed through some pain, your patients will secondary get swelling. So the color of the blood or the color of the fluid, I should say, is somewhat helpful from a diagnostic standpoint as well. Flip, please. So how do you tell when a knee injury is serious? Well, we kind of went through that, but in general, most traumatic injuries can be stabilized and treated on the field. They don't necessarily require an emergency room evaluation. Certainly, if they feel unstable, having some kind of brace or splint or immobilizer can be helpful. If there's a deformity that you have to reduce, that's a little different. And those patients maybe not only require bracing, but more immediate evaluation or assessment, including imaging. Also, if they have pain and they're unstable, but they can't walk, well, if you put them on crutches, tell them to stay off it, they don't have to rush to the emergency room that night. They can come to the office the following day, or we also have what's called an orthopedic urgent care, which is really specific to orthopedic problems. It kind of basically bills like an office visit, so it's not as expensive as like your average urgent care or your ER visit. And those people are qualified to make initial assessments with this, where they'd x-ray you and determine, hey, do I need an MRI? Do I need some kind of bracing, etc. In general, like a lot of the common advice we get for things like ankle sprains is remember rice. So rest, stay off it, ice it down 20 minutes on the hour, compression, some kind of ACE wrap or sleeve to keep the swelling down can be helpful. And then elevation. So elevate like kind of the limb or the extremity affected part above your heart. It's kind of like water, it runs downhill. So if you have it kind of down low, it'll just sit there or go towards your ankle. If you have it, propped up on the couch, it's a good way to help control some of the swelling in the knee and lower leg. And Tylenol and anti-inflammatories can be used for pain. We tend to discourage use of narcotics for most of these injuries just because they're not necessary. It might be hard to get people to get off them, frankly. We typically reserve those for more surgical type problems. So the initial goals for our knee injured patient, whether it's someone we see in the office, sometimes we see on the field, and then we're collaborating with the athletic trainer about how to manage these patients. First goal is always to decrease the pain and swelling. Use ice, use anti-inflammatories, use crutches or something to protect the weight bearing if they need it. Then work on range of motion. Putting them in like stiff braces or immobilizers is not preferred. The exceptions are probably with fractures and dislocations where you need to kind of reduce it or line it up, and then putting in something that will feel stable to them, like a cast essentially. But otherwise, essentially all of the knee injuries, we start moving right away, working on both getting their knee straight or extended, but also working on flexion. Now, the rate at which this occurs can vary depending on the severity of the injury, of course, but that's a general rule of thumb. They used to cast ACLs after patients got hurt years ago and treated them that way non-operatively, and they got stiff. And And so much of what we do nowadays, whether we're treating meniscal tears or ACLs or patellar instability, they're all about getting these patients moving right away. And so that's certainly a surgical principle we have, but also in the non-surgical setting. And most of these injuries are non-surgical. And also regain quad strength, meaning kind of tighten your muscle, try to force your knee straight, almost like do a leg lift, if you will, whether you're in a brace or out of it. That can be helpful to get the muscles working. And that also kind of bodes for a more normal knee recovery more quickly, especially if you're in season and something happens and you want to get back into the mix. And lastly, improve gait. And that means if you're hobbling or limping, use a crutch or two, or less commonly in this age group, a walker, but something that will help assist you to walk, kind of getting your knees straight and sharing the weight. And then with time, you can kind of wean off the crutches and walk. But if you're limping, I have no problem keeping patients on crutches a little bit longer, whether a non-op patient or a surgical patient, because if you limp, it puts a lot of pressure on your kneecap. It tends to perpetuate some of that pain cycle, and it's really counterproductive. All right, how are we doing on time here? So atraumatic knee injuries are just pain that can develop. Again, we talked about sometimes these things just come up over time. It's not really related to an event. It may focus on how often you're doing something, or hey, did you add this new workout to the day you're also playing pickleball? It may speak to how much rest and associated recovery you're giving your body. And all this can be affected by both strength and relative endurance or lack thereof. When you get muscle fatigue is when these things tend to happen. Also contributing is like muscle tightness or lack of flexibility. And as we get older, this is increasingly important because we tend to get tighter and we're more prone to some of these overuse type problems. The other age group that's really quite at risk for this is the pediatric age or adolescent patient. And the reason is they have open growth plates, or what we call a physes. So those are the growth plates close, often by say like age 12, 13, 14, and young females around the knee. Males might be a little later, but they're certainly prone to irritating the growth plate, particularly in the proximal tibia. And they develop these conditions called apophysitis, which can affect the proximal tibia. The most common is Osgood-Schlatters, that many of you may be familiar with. This kind of bump that people get below their knee from adolescence that will last forever. And typically it's okay. It's not something that has to be addressed surgically, but it can, kind of be a reminder of symptoms back at an early age. Other area where you can get it is in the bottom of the kneecap. There's like a patellar sleeve where you can get some apophysitis. And one of the reasons why this happens is these pediatric age patients are growing. So their bones lengthen or grow faster than muscles. So the muscles tend to be tight. So when you see these adolescents with these kind of knee problems, especially when it's both knees, it's almost always these overuse problems that are related to where they are developmentally, their growth, and the fact that they're often kind of tight and, either don't stretch adequately or just can't do it enough to kind of keep up, so to speak. Again, the muscle strains can anywhere from partial tears or pulls up to full-blown kind of higher grade injuries. But again, you rarely really tear your muscle in half. Tendonitis refers to inflammation of the tendon. The classic one we really see the most is what's called patellar tendonitis, or that jumper's knee. It really occurs right at the top of the patellar tendon at the bottom portion of the kneecap and the midline. The problem with some of these things is they kind of linger, people play through them, and then the tendonitis or inflammation becomes a tendinosis, which is where the inflammatory process changes and there's no longer an inflammation, but rather it develops some chronic changes or microscopic tears in the tendon that sometimes can actually even lead to surgery. And it's not common, but it can happen. And again, it's often a product of like kind of untreated issues or pain that patients continue to play through, that over time can evolve into this issue. And that's probably the one area we see it most commonly. Can you flip it? So these overuse injuries are the myriad of strains, tendonitis, bursitis. They're often attributable to training errors, meaning when patients make big jumps in what they're doing. And the running world is the most common offender, I would say. And so the recommendation is to limit increases in how often you run, whether it's don't go 2 times a week to 5 times a week, and how hard or fast you run, your intensity, and lastly, your duration. Like, don't go from 20 minutes to 60 minutes. A rule of thumb is to increase about 10% in each per week. It's hard to do that unless you're really on some kind of program, but that's a good rule of thumb as far as just limiting your exposure to developing training errors. And sometimes it's just a tendonitis, but when you get older and you do these things and you decide to run your first marathon at 50, some of these patients get stress fractures in their tibia from the running and the impact. So it's all, there's a method to the madness as to why there, these gradual increases in these running clubs that kind of help guide you on these things. Running surface is something I talk to patients about a lot, or it can even apply to walking for arthritic patients. Treadmill, track, trail are all a little more forgiving than pavement. So that can be a factor in these overuse injuries. Certainly poor conditioning. If you're just not doing some concomitant strength training, flexibility work, and then cardio, patients that just, do the same thing year after year, sometimes what I could do at 40 or 45 becomes very hard for me at 50 without doing some baseline strength training on the side. We talked a little bit about lack of flexibility in adolescents, particularly prone to be manifest during growth spurts. So that's something that we can't harp on them enough. No one likes to stretch. I get that, but it can really go a long way if you can get them to buy into that. And lastly, with overuse injury, especially in the runners, again, is changes in shoe wear. Hey, I got new shoes, can throw me off. I got some inserts or orthotics, and it just, now my knee hurts, my ankle hurts. So all these things are factors, and that we really will ask questions about all of them when we're trying to assess these problems with the patients when they come in. And generally try to get them not to run through pain. Pain's kind of like your stop sign or anything, lift through pain, etc. So here, that's my final slide, and then I'll let you go. So overuse injuries overwhelmingly treated conservatively. The first thing to do is to take away the inciting event. So if it hurts, don't do it. Rest is best, especially if you have a more significant problem where the patient can't walk and they're limping. Remember those principles of RICE, capital RIC, rest, ice, compression, elevation. We use a lot of therapy for pain control, stretching, and then subsequently getting back strength and endurance training and how to do it properly. I always tell patients, I'm not a therapist either. So, there's a method to it and a progression, if you will. And I can give you some exercises, but you don't really know sometimes the proper way to do them, but also the proper sequence and how to advance it, because you don't want to be doing the same thing 2 or 3 weeks from now that you're doing now. So therapy definitely has a role, even if it's once a week or periodically checking in with them just to help guide you to get back to whether you're running or skiing or cycling or what have you. In general, don't push through the pain. I say that a lot, whether it's, excuse me, more my older patients, but whether you're a runner or lifting or whatever you're doing, pain's a stop sign, and it's not normal to have pain. And similarly, adolescents, if you're a baseball pitcher and you have pain in your shoulder, don't throw with it, because that's not normal for you to have pain. So that's one of my kind of rules of thumb that I try to kind of impart on my patients, like your body's trying to tell you something. It's not that we don't want you to get back to that, but in the moment where you're having pain, we don't want to do that. MRI later in the course in these patients, you don't rush to it right away, because typically it's something that you are fairly confident that the majority of them will get better with conservative care, including rehab and rest. And if they don't, then sometimes you got to dig a little deeper, such as your patellar tendonitis patient that maybe has been lingering for a year or two. And lastly, they're rarely surgical. Sometimes you're doing near arthroscopy to quote clean up or debride. Occasionally, like open patellar tendon debris. I have an athlete recently. I did both of his patellar tendons over a period of a month, where he came in and did one, started the rehab, and then came back and did the other, because he really was suffering on both sides and felt like he couldn't get through the upcoming football season as he was currently feeling. So, but yeah, surgeries are it's less common in those patients. The last parting message: you don't always need to go to emergency room or urgent care, but we try to give you some of those indications where it's reasonable on the night of the injury. Otherwise, consider us. Call us the next day. We have access where we can get people typically within 24 hours somewhere. We also have 2 orthopedic urgent cares, one in Westerville and Pickerington, where we can kind of help people with these acute problems and try to get the expeditious care in a cost-effective manner. And I guess that's it. So I guess I almost filled up the whole time slot, but if anyone has any questions, I welcome them. I appreciate your time and attention and listening in tonight. Hopefully you were able to glean something that you can use and take away from this.
So I have a couple questions for you.
Okay.
Is ACL re-injury common?
Yeah, it is. It's all too common, especially in younger patients, especially in females. The most high risk patients are female soccer players. There's some data that suggests it could be within 15 to 30% when you consider a re-injury when you consider either the same knee or the other knee, which is kind of scary when you think about it. It's a lot. That's all too frequent. So we're trying to be smarter about how we deal with these patients, maybe change techniques, but also maybe do a little better job of preparing them to go back to sport and maybe even delaying it a bit more. It seems like in some of these patients that delaying the return is protective in some ways where it can start to lower that re-injury rate.
And should a partially torn ACL be replaced or repaired?
It depends. It depends if it's a partial tear where something happened and you're participating in a sport or activity and it tore that way, then generally, if you're an active patient and you're going to go back to those things, it's suggested to at least consider that, whether you repair it or reconstruct it. Sometimes you go off your exam, like how loose the knee is, because the MRI might read a partial tear that really doesn't feel unstable on exam. If there's any doubts, might as well put a patient to sleep and actually examine them, because that's how we could truly get a uninhibited exam, if you will, where they're totally relaxed. Sometimes in the office, it's hard to get them to relax. So in contrast, if it's an older patient with a partial tear, if they're not sure how long they've had it, they're not really doing a lot of, cutting activities, then maybe it's not as important. But in general, if it's a newer thing and you have what's felt to be a partial tear, surgery is considered, and this like repair technique that I mentioned is something that may be well suited for that. If it's like right off the femur or sometimes more towards the middle or top of the ligament.
And lastly, do you fix meniscal tears in older populations?
Well, you can. It depends on where the injury is. So I'm 57. The type of tears I get are typically more in that inner part where they're trimmed out and you move on. Now, if it's a big tear, it involves the majority of the meniscus and it's in the periphery where the blood supply is. Less common, but we do it in those cases because you don't feel good about taking out a huge part of the meniscus, because often those tears that are more peripheral are involve a huge part of the meniscus, and you just don't want to take all that out in anybody. When you say older is a relative term, too. I mean, many patients have associated arthritis, and you're smoothing or cleaning up the arthritis, if you will, and then trimming the meniscus. Now, the caveat is there's another type of meniscus tear called a root tear that is being more frequently diagnosed in patients, say 40 to 60 or 70. Typically involves the medial meniscus. It kind of pulls off the bone, which is like the anchor. And effectively, when the patient walks, it almost like pivots or pushes that meniscus out of the joint. So it's like, even though it's there, it's not really there. And so those were increasingly doing what we call the root repairs, where we anchor that back to bone, almost like pull it back into the joint space to kind of serve as a protector. However, it's a lot longer recovery. It's like a 6-week on crutches thing, 8 weeks in a brace. It's like a 4 to 5 month recovery in total. So it's a lot for someone to bite off, but it is good for the long-term health of their knee. So to answer your question, sometimes yes, in the older patient, much more common to fix it in younger patients, just because they tend to get different types of tears than someone like my age would. I hope that answers your question.
Thank you, Dr. Comisar. That concludes our webinar today. Thank you for participating in tonight's webinar. Our next webinar will be held on June 10th. Dr. Jeff Gittens will speak on foot and ankle injuries. Enjoy the rest of your evening. Good night.
Thanks.